you press. So typically हमने mobile वो बंद कर देते हैं अभी बंद कर देते हैं
Check.
Check, check. Check, 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 check. Hello, hello. Hello. Good morning, team. This is a sorting MATLAB Sigma machine. Whenever we want to start open the machine, there is a two locks. So we have to press this lock and then open it.
Check, check.
If we try without,
ये better वो रखो
if we try without this, it damage the lock. So we have to press and then open this.
lock कर दो
So to lock the trolley, there is a lock. Unlock this way, and simply by this way we can
So
lock.
this is a problem. What we have noticed is you keep pulling the trolley and it is locked, and you keep pulling, वो टूट जाता है lock. So just sure that ये खोलना है, then you move. Once you have moved it, you lock it. If you are keeping it some, let's say you're doing a procedure, you lock it, then you start your procedure. Okay.
This is a power button. If orange light is coming, so means power is there. We simply touch it and it convert into green and machine start on. The keyboard is divided into two parts. This is our B mode part and this is color Doppler part. So B mode, M mode and the gain is in this side. Color, pulse and continuous wave Doppler, and their gain is this side. This is time gain control. In one particular position, if you want to adjust the gain, that will be adjusted by this. Dual, yeah, brightness by this knob, sir. 2D. Sometimes what happens, we are, so this is gain control for B mode gain, M mode gain, and this is for color and pulse wave gain, sir. M modes are this side, sir. Yes, sir. B, M, and their gain, sir. And color, pulse, CW, and their gain, sir. Sometimes what happens, we find that the image in the pelvic region, image is coming very bright. So, this is, sir. This is time compensation gain, sir. That means one particular point पे अगर मुझे gain adjust करना है, so we use this. In the center, sometimes what happens, we while doing the E-fast exam, the image is very bright. So rather than changing the gain by this, if you press center button, it automatically adjusts the gain. Auto gain. It's a auto gain. Yes, center button in both.
अब आपका वो screen आ गया बताइए
Yes, sir. So we choose probes. Linear, cardiac, and convex probe is visible in this. Like we want to do the vascular, we select linear, vascular, and superficial. So वो ये अभी आ जाएगा.
Touchpad here,
Touchpad.
which you cannot see, you have to stand to see. ये है बड़ा important.
Check, 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 check.
Hello. I am loud. Okay. So what he is saying is there is presets. Okay. Presets है for this thing, for the probes. तो touch से आप select कर सकते हो linear, curvilinear and cardiac. ये तीन आपने देखा होगा already लगा हुआ है console में नीचे. All the probes are already attached. तो पहला step आपको वो करना है. फिर then you chose the area of interest. Like you want to do a lung, यू वांट टू डू कार्डियक, है ना. लीनियर पे जो आएगा आपका लीनियर वाला सारा आएगा, है ना. कर्वीलिनियर में कर्वीलिनियर वाला आएगा ऑलरेडी, और कार्डियक में कार्डियक वाला आएगा. देन यू हैव टू अगेन चूज इट. वो जो चूज करने के लिए वो टच पैड में ऑलरेडी प्रीसेट्स है, आपको खाली पिटना है उसको, है ना. करेक्ट. चल करके दिखाइए ना. एक जरा कर्वीलिनियर, मैं कहता हूँ कर्वीलिनियर करिए. अब जरा देखिए गाइस, लुक एट दिस. आ गया. थोड़ा गेन वो कर देना, थोड़ा गेन वो कर देना. हाँ बस बस. कैन सी दैट? यू अंडरस्टूड? या. इजी, इट इज वेरी इजी. योर जनरेशन विल बी मच इजी. तुम तो इसी में ही चलते रहते हो दुनिया में. चलो. ठीक है. So that is called focus. Means, you know, ऊपर से जितना आपके ऊपर से और नीचे से the midpoint, you know, where the target is, that is the focus, area focus. चलो. Yeah. Yeah, so that they know, everybody knows that how to, you know, see the orientation. Probe orientation he is talking about, okay. Additional feature है इनका ये लाइट है, LED लाइट है. But don't get, you know, think कि अगर लाइट नहीं जले तो आपको, है ना, प्रॉब्लम नहीं होना चाहिए. हाँ, so very physical, and the best part is to touch. You know that, touch करके. But that is okay. They know about it. They know about it. पानी.
Start? So very good morning to all of you. Today I am going to discuss one of very important topic, that is chemical disaster. Why it is important? Because our center is one of the center for CBRNE. And what is the full form of CBRNE? It is chemical, biological, radiological, nuclear and explosives. So to start with, the first thing which comes in CBRNE is your chemical disaster. So this is the case. I think all of you know about this unfortunate incident which happened on this 2nd and 3rd of December 1984. And why it happened actually? Because the Union Carbide India Limited, they didn't inform anything about that what they are making actually and what are the chemical hazard it could cause and how to prevent it. If there is a gas leak, what needs to be done in that case? There is no information whatsoever. So when the patient came, so 40 tons of methyl isocyanate actually released because of some abnormalities which happened. There is some explosion, there is gas leak which engulfed almost half of the city of Bhopal. So no emergency plan was made, and when the patient came to the emergency department, they were blind, they were gasping for breath. And the doctor, the physician who were actually treating those patients, they have no inkling whatsoever that what needs to be done in this case, how these patients should be managed. So this is important. This is an unfortunate incident. More than 12,000 patients died and lakhs of patients got affected. So this is not the first incident. Multiple incident I can quote that. There's one train which was carrying chlorine gas in 2005 in South Carolina and actually collided, and there is some mishap happened in the train, and due to that there was a release of almost 60 tons of chlorine gas in and around local area, which caused mortality of almost 10 patients only, because it was an open space, but involved at least 1,000 patients who got admitted because of some reason. Any idea about this Beirut port explosion? So there was a container, ship container, which was there from 2016, and here comes the role of rules and regulation on how to protect your chemicals. So this container, ship container, which was at the Beirut port, which is the capital city of Lebanon, it was having 2,750 tons of ammonium nitrate, and that was there for almost 4 years, 2016 to 2020. Suddenly there was an explosion, and this explosion was so huge that it recorded on the Richter, it causes some seismic effect. It recorded as 3.3 on Richter scale, and it's a massive, it's non-nuclear. इतना बड़ा एक्सप्लोजन पहले कभी नहीं देखा गया हिस्ट्री में. सो दैट वाज बेरूत, एंड इट वाज ए केमिकल डिजास्टर which released almost 2,750 tons of ammonium nitrate, caused injury, 218 people died, and almost 1,000 of the patients, more than 7,000 patients actually got affected, who were admitted at various hospitals in Lebanon. And this seismic activity was actually felt at Israel, Syria and neighboring countries also.
So why did this happen? So just on its spontaneous?
Because they were not able to control the temperature, there was some problem there. So again, very recently on 26th of April this year only, just a week back, there was an explosion at Iran, one of the ports of Iran. And they were saying that this was containing some fuel material for propellants, which is used for the making of propellants in rockets and missiles. Although the Iranian government denies it, but it released almost 50-60 tons of ammonium perchlorate, causing multiple injuries, multiple casualties and multiple injuries. They have reported 70 deaths on almost 13,000 injuries. Now these are the chemical incident which was not intentional. ये accidental था. Now come to the accidental नहीं, intentional, where actually you use the chemical weapon to harm the people. So this was any idea about Iran-Iraq war? Iran-Iraq war was fought from 1980 to 1988, and from 1983 till 1988 Iraq was continuously using chemical weapons, either in the form of nerve agents. Mainly they used the sulfur mustards, causing thousands of deaths of Iranian soldiers. And still, if you go Iran, there are war veterans where you can see the adverse effects of sulfur mustards. So it all started in 1915 during First World War, when the Germans used chlorine gas in Belgium in 1915. Again, same German used nerve agent, sulfur mustard in 1970s, where 20,000 at that point of time, 20,000 of the soldiers died. So it's a war tactic, and people have used multiple times in the past also. So chemical weapons can be used as a weapon against the army, against the opponent's army. Any idea about this? So it happened in Japan. So there is one metrochemical attack in the form of sarin gas, they leaked sarin gas. And there is a city called Matsumoto where the chemical attack, there was some rebellions in the Japanese, there were some terrorists in Japan, wanted some liberation or something like that. They used to actually use chemicals to actually terrorize the people. So this is all about chemical, use of chemical intentionally just to have an edge in the war. Second, it can be accidental. So we are mainly concerned nowadays for accidental release of the chemicals which can affect badly to the people. So what is a chemical disaster? It is nothing but uncontrolled release of chemical from its containment. So if there is an industry where you have a containment where the poisonous gases and the poisonous chemicals are stored there, but somehow there is a leak or there is an explosion in that containment which can release these chemicals, and this cause chemical hazard to the people. I have already enumerated a lot of examples where it can be deliberate, it can be accidental. So one thing, what is hazard vulnerability assessment? Suppose there is an industry in and around All India Institute of Medical Sciences, New Delhi, and it is using some chemicals or some biological elements. So you must know that what they are using. If there is a leak or an accident, is there any emergency action plans that they have? Is there any available antidotes? So it's all about that in and around Delhi, what are the things which can affect you? This is hazard vulnerability analysis, and you may get short notes that what is hazard vulnerability analysis. If you do hazard vulnerability analysis of Delhi, this is the thing that you will get, that it is Delhi in the seismic zone 4. So more and more chances that you may get earthquake of severe intensity in the future. So the disaster response should be accordingly made and should be multiple times you have to do the drills. So in case of any disaster which is related to earthquake, how to manage. Okay, so there should be a proper disaster plan which should be there, and you can actually execute this disaster plan when it actually happens. So this is your hazard vulnerability analysis. So suppose there is a chemical blast or a nuclear blast, something like that happens. There is this epicenter, which is the main center of the chemical emergency, and there is a penumbra effect. Like, for example, a stroke. If there is a blockage of the artery, there is a core infarct, core zone, and there is a penumbra. Similarly, there is an epicenter and there is a penumbra effect. क्लास में हमें why it is important to know about the evacuation plan and the disaster plan. Simple example, most of these gases, chemicals, they are heavier than air. For example, methyl isocyanate, they are heavier than air, so they settle down near to the earth rather than it go up. So people actually who are actually comfortably sitting in third and fourth floor, they also came down when they hear the news that there is a something happened. So they all got affected. So this is the importance of information. If you have information that if something happens, I have to remain on the top, probably you will be saved. So this is the importance. So this is hazardous materials guide. Hazardous materials, if there is something problem happens, then there is a guideline that how to approach hazmat. So community risk assessment. I have already told you that there is a concept of hazard vulnerability analysis. You have to know that what are the hazards looming around, and if there is something happens, how to actually manage it, how to mitigate it, and how to manage it. And state level, national level, at every level there should be a disaster plan. At your hospital level also there should be a disaster plan. So the second important thing is that if there is release of chemical, how will you know that there is something wrong and there is a release of chemicals? Very simple. Lot of people will come with the same sign and symptoms, like lacrimation ho raha hai, there is drooling of saliva, there is increased diarrhea, something like that. So most of the people will come in with the same sign and symptoms. Some unusual odor, some irritation is there, and apart from that, they will also report that the patient, the lot of people, healthy people who are earlier on healthy, there is no comorbidity, they are dying with the same sign and symptoms. And they may be associated with some mortality in animal and the birds also. So if these things are there, then you have a suspicion that probably something is wrong there, and you start searching for it. So identification of the substance involved, how will you identify? It will be a toxidromic approach. For example, if there is a nerve agent which is responsible, then it will have an OP-like features. Similarly, if there is a release of chemical which has having alkylating properties like blister forming, like sulfur, mustard, nitrogen, blisters are formed, ocular involvement is there, respiratory symptoms are there, so it will be having some syndromic clinical manifestation. And you have to know that, we all know that in all the toxin, there are limited number of antitoxin which is available, just mainly just specific effective antidotes which is available against a particular type of toxin. So isolation and scene control, establish an incident command. Wherever there is an incident, you have to do some incident command, you have to establish the thing, there should be an incident commander, and everything should be in place. So my question is, if the incident happens here, where will you establish an incident command system? You are from military, so somewhere in the penumbra. No, कैसे करो?
Cold areas में like not in the it could be both in the field and in the main hospital that the treatment is implemented.
Okay.
Both areas need an incident command. Like,
Okay, I am just talking about field command system. कहाँ पे रखेंगे?
A cold area, like we have the
Cold area.
In the cold area after
And This is the center, epicenter. Cold area can be this, cold area can be this.
It could
How
be,
will you
It
decide?
should be it should be upstream and uphill.
It should be upstairs, uphill.
Uphill
मतलब
and
थोड़ा
up-
सा ऊंचाई पे होना चाहिए. Second,
uphill and up. Wind नहीं होना चाहिए in the direction and
upwinds.
हाँ.
Suppose the wind flow is from north to south, so
North.
towards north, not towards south. If there is something which is actually there is some chemical in the river or some ocean, then
Upstream.
upstream, not downstream. So uphill, upwind and upstream. Clear?
And how far, sir? How far have you described it? That
It-
depends on the.
No, no, it all depends. It's a very good question, Akshay. Okay, how far your cold zone should be. So cold zone, there is no specific guideline depending on what chemical, what materials was used, and so it is not fixed. But overall, they say that for gases, it should be at least 100 meters from the epicenters by convention. Again, you have to see how toxic the gas is, what is the wind flow, what is the ambient temperature, it all depends. But 100 meters for gases, then around 50 meters for your liquids, and maybe less than that for solids. So 25, 50, 100 ऐसे कर लेते हैं. 25 meters for solids, 50 for liquids and 100 meters for gases. But again, it is not very fixed. The most important thing in any disaster, you want to protect the people, you want to move the affected people from the epicenter to a safer zone. So extrication or removal of the people from the exposure is more important. So these are the three zones. One is the epicenter, which is called the hot zone. So only those people with proper PPE, with proper training, which is known as the first responders, they should go and they should bring those who are affected. Then you have to, in the warm zone, just triage the patient, decon the patient, and then there is a cold zone. Okay? The hot zone, warm zone, and then cold zone.
This is a very important figure from
Tintinale.
You can see the decon area is your warm zone. The cold zone, after decontamination, they come to the cold zone, and in the cold zone is where your medical team is. The emergency department is in the cold zone. So after they move to the
Again,
cold zone,
you can do multiple times your triage, but basically triage at the hot zone, the warm zone, and the cold zone varies. You understand? Okay?
and chemical disaster, you need the highest level of PPE, which is available, sir. I think
हाँ,
will show.
हम बोलेंगे,
And
बताएं.
that is in the hot zone. में NDRF के जो लोग जाएंगे, they will go to the hot zone, rescue them, bring it, but they will not provide any resuscitation there. They will not do anything for the patient. Everything will be done after decontamination.
So this is also taken from one of the chapters. So the main primary responder will enter the hot zone, and as Dr. Akshay told you all, that the main purpose of entering that area is just to rescue the people. Okay, then they will come to the warm zone. Here you do decontamination, and after decontamination the patient will exit with a plain clothes to the cold zone where the proper medical treatment can be provided.
This is all outside the hospital. The field.
So I am talking about field only. So contamination can be of two different types. One is the primary contamination and second is secondary contamination. So what is the difference between primary and secondary? That there is a chemical disaster and I am exposed to that chemical, primary contamination. So you are a medical personnel, you are going to in that area and giving us treatment, you get contaminated, or few people came to the hospital without decontamination and you are exposed to that. So that is called secondary contamination. So what are the chances that you can be contaminated? Sally. Secondary contamination. Secondary contamination is very common in first responders. But is there any incident happened in the hospital where secondary contamination happened to the healthcare workers. And the perfect example is the Tokyo sarin gas trap. So most of the people who are relatively stable, they came from their personal vehicle to the hospital first. They were not properly decontaminated and they came to the hospital. So 46% of the healthcare workers got exposed, though the exposure was much less. So they developed minor symptoms only and nobody got the severe symptoms of nerve agents. But just try to understand, there are chances that if you are outside hospital, there is no separate decon area, you may get exposed. Depending on the level of exposure, you may develop symptoms and signs.
So the goal of decontamination just outside
the hospital is also
all
important.
The victims who are coming, even the ambulance staff who are coming, should get decon. Then they come
Then
and
they come.
talk to you. Otherwise, you will get tertiary contamination.
Important thing is that you have to check, you have to ask, decontamination was done in the warm zone or the cold zone, or agar answer is no, then you have to reassess the patient. So do you have any decon area in your emergency?
ट्रॉमा सेंटर
ट्रॉमा में है यहाँ पे
नहीं है।
जो
We can
डॉक्टर
use
राकेश
that.
यादव का रूम है ना, उसके बाहर जो रूम छोटा वाला है ना, दैट इज एक्चुअली डिकॉन एरिया. हाँ हाँ, छोटा वाला रूम.
नहीं, अभी सर EM1 के बाहर वो जहाँ पे वो पेड़ लगे हैं ना सर, that was told verbally.
यहाँ ऑपोजिट वॉशरूम्स है ना, पेशेंट यूज उधर ऐसे
हाँ, बना
बीच के शावर उधर से भी करा नहीं, वेटिंग नहीं, वॉशरूम्स है ना पेशेंट.
So this is about what sort of PPE you will be using when there is a chemical disaster. So you all know that there are four different levels of PPE that you will go. One is the A, B, C and D. So what is A? You can see here, sorry. You can see here there is a self-contained breathing apparatus inside the encapsulated suit. It is totally chemical resistant. So even the SCBA is also within that chemical resistant suit. Okay. It is required when you need highest degree of protection for skin, eye and the airway. Okay. Suppose you need a PPE which is needed for higher degree of protection against respiratory system but less for the skin and the eyes, you will go for level B. Level C, basically in the cold zone, the healthcare workers, they will be wearing C, and D is just what you are doing in your hospital, you can use that. So what is in a chemical disaster, what is mandatory? There should be a hat which is hard hats. Hard hats. ऐसी जगहों पे क्या होता है कि ऊपर से कुछ गिर सकता है, तो you need a hard hat just to protect your head also. Number one. Number two, fully encapsulated suit which is chemical resistant. Gloves, which should be double gloves and it should be made up of hard rubber. And then there should be a shoe with a shank. The heel should be steel, shank should be made up of steel. Okay, and then an SCBA. It will take you lot of time to wear. You need practice, and it is really difficult to wear it for a prolonged period of time. You can just go and come, so that you can remove the affected people. You cannot wear for hours and hours. Very difficult. कभी पहना है इसको? पहन के देखना. So there is a prescribed guidance for chemical incident. First of all, you have to confirm that there is a chemical disaster, what sort of disaster it is, and then just go and evacuate, then disrobe, decon, and then proper treatment. Now come one by one. This is how you decon the patient. You have removed the patient from the scene. There are two different types. One is, you can see here, there is called dry decontamination. Just if you see that there is some solid element, some chemical is there, just with the help of non-abrasive cotton material, or a sponge, you can clean it. Second is the wash. Just you can wash it with the help of soap and water, and probably you will be able to decon the patient. And there is a concept of mass decontamination. What is mass decontamination? You can see here. ठीक है ना, आपने पानी लगा रखा है, उस पर लोग जा करके कर रहे हैं. So ये important है जानना कि what should be the temperature of this water. So ideally they say that it should be 35 degrees Celsius. But don't wait that it is 35. अगर 32 भी है तो क्या फर्क पड़ता है. The whole idea is that it should not be very warm so that it can cause further injury, and it should not be very cold to induce hypothermia or further injury. So as a 35 है, just for examination purposes, just to answering the question of the external 35 है. And it should be high volume, low pressure. High volume, low pressure. And what does high volume means? It should be 60 pounds per square inch. 60 psi. Okay? So to think 35 degrees Celsius, high volume, low pressure. This is how you can, this is ladder decontamination system is there. The patient just pass through it and he will be decontaminated. And just in the cold zone, you can make a decon area where further decontamination can in a proper way. Patient will enter through it, enter through it, then after decontamination, with wearing clean clothes, will come out from this side. Okay. And the rescuer, basically the first responder, they have also to be decontaminated. So this is the way they should be decontaminated. The important thing that you have to notice that they are actually accumulating these contaminated material which is coming out. So ideally it should be disposed properly. But even if it is not there, you can dig a pit and put it there. एक ही चीज़ देखना है कि वो किसी तरह से वाटर सिस्टम या किसी और चीज़ से रिलेटेड ना हो. आप लोगों में कितने लोगों ने देखा था जब ट्रॉमा में हमने रेडियोलॉजिकल वो इस्टेब्लिश किया था NDRF में? हाँ, योर एक्सपीरियंस बताओ कैसा था? हाँ, so they made a tank like thing. So because radiology you have to prevent the ionizing radiation to come out, so they made a something concrete tank, na? So I am talking about the chemicals. So chemicals, there is no risk of ionizing radiation, but only thing that you have to think that it should not come into the water system, or people should not be using water of that area. So what is the PRISM rule of 10? I am exposed. I was at the site of, I was epicenter site पे मैं था यहाँ पे. Then by just removing my clothes, I can get rid of my 90% of contamination. Then you can have a mass decontamination, just soap and water. It will reduce the contamination from 100% to 1%, and then maybe a technical decontamination, eye कर दिया, oral cavity किया, and then you are 100% free. So what is the importance of disrobing? Again, unfortunately what happens that whenever there is a disaster, so much people will gather around, and disrobing will be a very difficult job at that point in time, mainly for the females, which is understandable also. So how much they can disrobe, let them decide, but try to keep these media people and unnecessarily people at bay, so that disrobing will not be a problem. Okay. So you can see here, after disrobing with only in undergarments, you can see that there is only this area which is contaminated, without disrobing, there is still some amount of contamination is still there. So it all depends that how much disrobed the patient was. So about triage and stabilization, you know that triage should be done in the cold area, and whatever treatment you have to provide there only. And in the cold area, when you will place an IV line or some important thing, that if you have to give some drugs to control the seizures, some arrhythmias like hypoglycemia, something like that, which is very important for the management of the patient, which cannot be done or which cannot wait. Now, triage in the emergency department is entirely different from the triage in a mass casualty area. So, do you know any triage system? One is the START. In pediatric group, it is called Jump Start. And there is also a triage in the mass casualty, which is called SALT. So, I will be discussing about what is START. It is nothing but simple triage and rapid treatment. So, how will you triage? Number one, पेशेंट को कहो कि आप में से जिनको जो चल सकते हैं वो इस तरफ आ जाएं. अगर दे कैन वॉक एंड मूव फ्रॉम वन प्लेस टू अनदर प्लेस without any cardiorespiratory abnormality, they are green patients. They are walking patients. They are green. They can wait. Second is, if patient is still unresponsive, like just try to open, just a head tilt chin maneuver, jaw thrust. Still patient is not breathing. That patient is disease black, tight in black. Any patient who is breathing with a respiratory rate of less than 30, capillary refill time of less than 2 seconds, and patient can do simple command, patient will be labeled as yellow. If the respiratory rate is more than 30, refill time is more than 2 seconds, and the patient cannot do simple commands, cannot follow the simple command, patient is red and patient should be shifted immediately. So this is again more or less same, that is SALT triad. This first is SOT. SOT is simple. How many of you can walk, how many of you can wave, and how many of them are still looking like they are unresponsive. So this is SOT. Then you assess for some important thing, whether the patient is breathing or not. If your patient is not breathing despite maneuver which opens the airway, patient is diseased and patient is black. Okay. Again, SALT में SA, what is L? That is life-saving intervention that you have to provide. What is life-saving intervention? If the patient is bleeding, just control breathing. If patient is bleeding from somewhere, just control hemorrhage, open the airways. If there is anything that is a tension pneumothorax, just put a needle. And if you know that this is the chemical and effective antidote is available, give antidotes. That's it. Then again you come to the same start like the addition is only one, there is a gray. So if you open the airway and the patient started breathing, but you decide that in the given circumstances and with the given infrastructure you have, manpower that you have and the treatment facilities that you have, you will not be able to save this patient, then that patient will be labeled as gray. And this patient should not be given priority. So this is the addition, rest is more or less like START. So this is the difference between SALT and START. So in hospital, victim arrive, you again assess. Is there any evidence of contamination? So if there is any evidence of contamination, there should be a decon area just outside the hospital, decon the patient and shift the patient to the. Only sometime when patient needed some life-saving measures, you can take the patient to the ER and you can simultaneously do the decon. So as much as possible, try to decon first and then treat the patient. Okay. Now, what are the different types of chemicals you know? What are the different types of chemicals you know? The first chemical is the nerve agents. कैसे पता करोगे कि there is a nerve agents here? There is an exposure by the nerve agents. So it's like OP poisoning, like you know, sludge and everything. There is increased salivation, increased lacrimation, there is increased bronchoria, bronchospasm. So clinical features of nerve agent is more or less similar to that of OP poisoning. Here the only difference is the rapidity by which it develops symptoms. So it is within seconds to minutes. Okay. And again there are slight difference sometimes that muscarinic effect can be superseded by the nicotinic effects in nerve agent sometimes. So nicotinic features क्या होते हैं इसके? Fasciculations, paralysis, hypertension, seizures. Okay. Now the second is in the blistering agents. It is a oxidizing agent basically, alkylating oxidizing agent. So multiple blisters will be formed. There may be ocular involvement and there may be respiratory involvement. So it all depends on the ambient temperature, which type of symptom will be more seen. For example, if it is in the cold environment, suppose there is a attack in Delhi during winters by sulfur mustard. So at that time temperature is around 5, 6, 7. So it will be in the liquid form. So the chances of respiratory involvement is much less. So it is more skin involvement. Similarly, during Iran-Iraq war, it was in hot season. So more and more respiratory and ocular features were there. So it all depends on the ambient temperature, that which type of symptoms will be more in the sulfur mustard. Asphyxiant, any example of asphyxiant? Okay. Irritant gases? Ammonia. Okay, we will discuss right control chemicals. So you may see lot of cases of right control agents, chemicals. So a lot of people will come to your emergency with this. So simple asphyxiant is nothing, carbon dioxide, hydrogen, nitrogen, noble gases. It all depends. What they decreases the FiO2. So they decreases the oxygen concentration you inhale actually. So depending on the FiO2, you may develop symptoms. For example, if it is less than 16%, patient will have some air hunger, tachypnea, nausea, and vomiting. But if it is less than 10%, patient will have loss of consciousness and maybe seizures. Nothing doing, just decon the patient, remove the patient from the source and give a good amount of oxygen and patient will be alright. Second is irritant gases, ammonia, chlorine, hydrogen fluoride, phosgene. So again, it all depends how, which type of liquid it is, how much water soluble it is. So for example, ammonia is very water soluble. So the chances of getting symptoms very early with ammonia. Phosgene, less water soluble, but it is more dangerous because you will not be able to perceive it first and it will have a aftermath. So पेशेंट को कितना सिम्टम होगा डिपेंड करेगा कितना वाटर सॉल्युबल है वो. सो अमोनिया नंबर 1 विल प्रेजेंट द सिम्टम्स वेरी अर्ली. सो जैसे ही आपको पता चलेगा ना कि कुछ यार कुछ गड़बड़ लग रहा है, यू मूव योर सेल्फ अवे फ्रॉम दैट सीन ना. बट इफ यू आर अनअवेयर दैट देयर इज सम phosgene in this room and you cannot perceive it, you will be exposed much more. So problem will be more. So this is the problem. You all know that hypocalcemia is a problem with iron chloride poisoning. Right control chemicals, multiple things, CN, CS, PS, you all know about it. Nothing, they don't cause mortality, and that is why it is commonly used as the right control agents. ये basically solid होते हैं, sometimes they are liquid, but they are vaporized. So it is used in the form of gases most of the time. They cause lacrimation. They are also called lacrimators and sometimes irritants. तो कफ होगा, ब्रोंकोस्पाज्म होगा and खूब lacrimation होते हैं. So they will come to the hospital. Most of the time they don't come to the hospital. कितनी बार होता है कि वो hospital आ ही नहीं है. Just 10-15 minutes away from the sign, so from the site, they will be completely normal. There is no need to come to the hospital. But sometimes mortality may happen if you are entrapped in a place where there is a continuous exposure is there and you cannot come out from that place. So in that condition, sometimes mortality has been reported. But most of the time it is very, very benign and most of the patient will not come to the hospital. अगर आ गए तो क्या करोगे? Decon, just give oxygen, patient will be normal. Wash, it's okay. Oxygen transport inhibitors, you all know that how carbon monoxide poisoning should be managed. कैसे करेंगे? 100% oxygen, try to give 100% oxygen. Chemical asphyxiant like cyanide, hydrogen sulfide, phosphine and sodium azide. Have you seen any patient of hydrogen cyanide poisoning? कैसे when to suspect hydrogen sulfide poisoning?
Tachypnea with normal oxygen.
Hydrogen sulfide is fever gas, and then cyanide is cyanide. So how the patient will come to you?
Shortness of breath, neurological involvement, shortness of breath, respiratory involvement, either cardiovascular, pulmonary, pain involvement will be there, tachypnea will be there.
Why these are called knockout gases? Can it be a very good source for using against the enemy? Against the enemy. आपकी फाइट हो गई पाकिस्तान के साथ. Can you use hydrogen sulfide or hydrogen cyanide? People have tried in the past also. That is why I am saying that it is not a very good source. It is not very effective. Why? It has a all or non phenomena. या तो पूरी तरह से मर जाएगा in a small area, but it will not have a very good effect if there is a dispersal of these elements. अगर जैसा वो हाइड्रोजन सल्फाइड तो निकल रहे होंगे ना, सीवर गैस तो निकल ही रहे होंगे, तो सीवर में जब तक आप जाते नहीं हैं विथ ए पर्टिकुलर ppm एक्सपोजर, पार्ट पर मिलियन एक्सपोजर, देयर इज हार्डली एनी साइन एंड सिम्पटम. द मोमेंट यू गो इनसाइड दैट पिट द प्रॉब्लम स्टार्ट्स देयर. बट बाहर तो थोड़ा बहुत तो रिस्क आता ही होगा. इट इज गेट्स डाइल्यूटेड. सो द आइडिया इज this chemical asphyxiant can have a very potent effect on the patient. Hardly they survive. कितने पेशेंट ऐसे हैं जो सीवर गैसेस के इमरजेंसी आ रहे हैं? कभी नहीं देखा होगा, नहीं, बहुत रेयरली. या इट्स लाइक ऑल एंड नॉन फेनोमेना. वहाँ पे जो हो गया सो हो गया. एंड रेयरली द पेशेंट कम्स टू द हॉस्पिटल. व्हेन द पेशेंट कम्स टू द हॉस्पिटल, व्हाट विल यू यूज़?
If it's short, cyanide toxin, it's cyanide antidote or methylcobalamin.
So, inhalation form में amyl nitrite is available, sodium nitrite is available, sodium thiosulfate is available, but the drug of choice for treating hydrogen sulfide or the hydrogen cyanide toxicity is hydroxycobalamin, and dose is 5 gram over a period of
50.
around 15 minutes. Okay. Now tell me, what would be the major changes in arterial blood gas?
PaO2 will be normal in case of cyanide toxicity.
So PO2 will be normal.
SpO2 also normal.
हाँ.
Mixed oxygen.
Venous and arterial blood में difference कम हो जाएंगे. Anything else?
Lactic acid.
Lactate will be on the higher side, more than 10. Okay. Then you suspect that probably it is hydrogen sulfide or hydrogen cyanide. I have discussed. So in the combat zone, Vignesh, in the combat zone, if you are thinking that there is a risk that Pakistan can use nerve agents, so what is the available antidote which you will carry with yourself? Like ऑपरेशन डेजर्ट स्ट्रॉन्ग हुआ था ना इराक में, ठीक है ना, तो देयर वाज अ रिस्क दैट यू कैन बी एक्सपोज टू द केमिकल एजेंट्स. So what will you give to your army?
Anticholitis diacetyl.
So most of the time they give 2 milligrams of atropine, 600 milligrams of pralidoxin and 10 milligrams of diazepam as an antidote. And trust me, this nerve agent is slightly different, though the sign and symptom is very similar to that of opioid poisoning, but the requirement of atropine and pralidoxin is very, very less. So this 2 milligram of atropine, 600 milligram and the 10 milligram benzodiazepine will save you, and you can reach the hospital and get the treatment. So the requirement is less. This is the major difference, though the sign and symptom is very, very early and very severe, but it is for a short period of time and it requires less amount of atropine compared to your regular OP. So this is what military people actually carry with themselves. Blistering agent and how it should be managed. So the first and the most important thing in any chemical agent is the decontamination, and I have discussed in detail that how to decontaminate. अगर आइस को डिकॉन्टामिनेट करना तो क्या करोगे? इरिगेशन कैसे करते हैं?
Source limited setting, nasal prongs में medial end में रख के उसमें ठीक है.
So the flow of the fluid should be from
Nasal to
nasal to
temporal.
medial to lateral कह सकते हो या nasal to temporal कह सकते हैं. And there should be a kidney tree here, so that it should not actually expose the local soft tissues and other things. And give pediatric topical antibiotics, oral analgesic, petroleum jelly. Petroleum jelly should be given at the eyelids margin only. ठीक है? What to do when there is a skin involvement? Again, decont the patient, wash it with proper water and soap. Sometimes Fuller's earth can be used. Fuller's earth होता है ना, मुल्तानी मिट्टी. Fuller's earth. मुल्तानी मिट्टी यूज़ किया है कभी? Fuller's earth. And even देखा था? फेस वॉश के लिए यूज़ करते हैं ना मुल्तानी मिट्टी. Fuller's earth. And you can use the bleach. You can also use the bleach, sodium hypochlorite in a diluted form, 1:10 dilution, जो household bleach आती है ना, it should be dilated to 0.5% and you can use that also. TT prophylaxis, fluid management, antibiotics. If there is involvement of the lung, then again the bronchospasm will be there. Bronchospasm, chronic bronchitis, then there are chances of emphysema later on, bronchiolitis obliterans and renal lung damage. How will you initially manage? Just give oxygen, decont the patient, give oxygen, give bronchodilators, and if there is involvement like tracheobronchitis, something like that, you can give 2 things. One is you can give steroids, you can also give sodium bicarbonate. Any concern in the special population? For example, pregnancy है and there is a chemical disaster and patient got exposed. I don't think there is any report. For example, Iran-Iraq war, ठीक है ना? So there is hardly any information regarding teratogenic effect of these chemicals, and it has not been reported in the pediatric age group that after the delivery there is some problem actually noticed in the child, and it is not leading to any adverse event even in the during pregnancy also. So no report as such, except few case series and case report, that's it, that it has some adverse event on pregnancy. Number one. How infants and children will be affected? Any difference? Infants will be affected more. Infants and children will be affected more or less.
More.
Why more?
High base area as compared to
Later
surface
एक करके ना.
body surface area. as
So the
compared
body surface area to mass ratio will be higher. So there are chances of more and more absorption. Number one. Number two,
Lung functional capacity.
lung function capacity surfactant will be less. So chances of more damage. Anything else? Because these are heavier than air, so more chances of settling down. So more chances of infant and children exposed. And there are some protecting enzymes are there, that is called peroxinases. So peroxinases are less in infants and children, so the chances of their involvement is much more. And one important thing, इनको ना डिकॉन करने के लिए यू नीड सम केयर. इनको थोड़ा डिफ़िकल्ट होता है डिकॉन करना, इनको डिफ़िकल्ट होता है ना बच्चे को गोद में लेकर ये कुछ कर. सो डिकॉन्टामिनेशन इज़ ऑल्सो ए चैलेंज. सो दीज आर द चेंजेस, दीज आर द थिंग्स दैट इज़ related to pediatric age group which can lead to adverse event in a chemical disaster. So do not panic, decontamination is the most important thing in chemical disaster. Use PPE, protect self and others, on-site and off-site emergency plan, mock drills necessary. तो हम ना कभी इस पे mock drill करेंगे यहाँ पे, ठीक है? Thank you very much. Any question?
Abhishek, can you read the case? How will you proceed with the case? CNS एग्जामिनेशन में क्या देखना चाहोगे? So, based on the history, what are your differential diagnoses? Okay, settle. Today I will discuss about presenting with similar complaints. One of the important differentials, malaria. Good morning everyone. I am Dr. Shantimay Singh Sardar, Junior Resident, Emergency Medicines, and my moderator is Dr. Akshay Kumar Sir, Additional Professor, Department of Emergency Medicine. Today's our objective is epidemiology of malaria in India and abroad, pathophysiology of malaria, clinical features of malaria, and it's a evaluation of suspected malaria cases, treatment to specific malaria parasites, special consideration, chemoprophylaxis, vaccine and others, and emerging challenges. For epidemiology, first we are seeing a histogram. Here in the blue bar we can see the Plasmodium vivax cases, and in the orange bar we can see the Plasmodium falciparum cases, and the yellow line depicts the deaths related to malaria cases. In this histogram we are seeing that from 2000 to 2022 there is a marked decrease in presenting cases and cases related death related to malaria cases. And in this diagram we are seeing the API annual the cases presenting annually in 2015 and related to 2022. There is also a marked decrease in the presentation and also in the concentration of presentation. In the global in 2021 there are 249 million cases in malaria in 85 endemic countries, and malaria deaths are recorded as 6,08,000. In India in 2022 total malaria cases were 1,76,000 and falciparum cases 98,000 and total deaths were 83. Our government Ministry of Health and Family Welfare in National Vector-borne Disease Control Program, they released National Strategic Plan Malaria Elimination 2023-27. In that their vision was Malaria Free India, mission is malaria elimination by 2030, and goals are interrupted local transmission, achieve zero indigenous case throughout the country by 2027, and provide an enabling environment to prevent re-establishment of malaria. And strategies implemented are transforming malaria surveillance as a core intervention for malaria elimination, ensuring universal access to malaria diagnosis and treatment, ensuring universal access to malaria prevention, accelerating efforts toward elimination and attainment of malaria free status, promoting research and supporting generation of strategic information for malaria elimination and prevention. For causes of malaria, it is caused by Plasmodium parasites. There are 5 species of malaria which causes malaria in human beings are Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae and Plasmodium knowlesi.
Sorry, Shantamoy.
Huh?
What is Plasmodium?
Plasmodium is an amoebic amoebia which transmitted by Anopheles mosquito to cause the malaria disease per se. The disease is transmitted by female Anopheles mosquito. Life cycle of malaria. As you can see, we can discuss it from the when mosquito takes bite and take a blood meal.
So you show it with a pointer, ना? कहाँ पे हमें देखना है मतलब it's a busy slide. So start where is the bite? Step 1 है ना?
Step 1.
तो उसको उस पे activate कर लो pointer. Can somebody help?
iPad में से
iPad से कर रहा है?
iPad से कर रहा है।
हो जाएगा presentation mode में. Without that we will not know ना कहाँ पे तुम दिखा रहे हो.
नहीं
ये कंप्यूटर नहीं चल रहा है क्यों भाई कंप्यूटर नहीं चल रहा कंप्यूटर स्क्रीन इज नॉट वर्किंग हाँ अच्छे से एक्सप्लेन करो
Step 1
यस प्लीज हाँ
Step 1 we can see that when mosquito takes the blood meal, it injects the sporozoites with the saliva. It enters flow to the liver cells and there they infect the liver cells. Then they form sezones there. Then the sezones rupture and the trophozoites are released. The trophozoites then infect the RBCs and then they mature into trophozoites, then form sezones. Then they rupture again. Then those new trophozoites reinfect human blood, new red blood cells. The few of the immature trophozoites also transform into gametocytes, and then the male and female. Then when the mosquito again takes blood meal, they enter into their sexual cycle, and they then form oocysts, and then when they rupture, they release sporozoites from there. Those sporozoites are lodged into the salivary glands of the mosquito and then again infect the new human beings.
So when do you get fever? Febrile phase का होता है.
Febrile phase जब होता है जब RBCs when they rupture, they release the toxins, then the febrile spike of the fever happens.
Merozoites time, merozoites भी होते हैं. ठीक है
Presenting symptoms, most common presenting symptoms are high grade fever, chills and severe headache, nausea, vomiting, muscle pain and fatigue. In severe cases, organ failure, coma and death can also happen. In malaria cases, we have to take proper history and we have to take the symptom profile, onset, progression and pattern of the fever, severity of the symptoms, preventive measures taken by the patients, any past medical history, especially any past history of malarial disease or any medication. Some medications can interact with the anti-malarial drugs. Social history also, because their occupation can make them vulnerable to malaria, exposure to malaria. Travel history in India, it is not that much important because it is endemic in India, but outside it is not endemic like US or UK. The travel history may also be important. Systemic examination, we have to see the general appearance of the patient. We have to document the temperature, look for pallor and icterus, look signs of hypotension or shock, and look for signs of pulmonary edema On para-abdominal examination, there can be hepatosplenomegaly and look for focal neurological signs or meningeal signs or seizures. For laboratory investigation, microscopy examination like thick and thin blood film, Baffi-coat, rapid diagnostic test, and it's a PCR for parasite DNA can be done. Microscopy examination is gold standard for diagnosing malaria. Here we can see a thin film of thin blood film,
जाके दिखाना पड़ेगा where
thin blood film for malaria.
पास में जाके दिखाओ ना कौन सा
Here we can see the ring forms in the RBCs. Multiple ring forms are there. And so you can see also
So ये this can be an exam question also spot में आ सकता है आपके ठीक है ना so you should know कि जो आप different gametocyte दिखाना है वो और क्या क्या दिखाओगे इसमें ring forms ठीक है
so there in the WBC also there can be some pigments can also be seen.
pigmentation in the WBC. So this should have been annotated or you should use a pointer ना अभी ये तुमने iPad से connect कर लिया या लैपटॉप ले लेते तो you could have shared a pointer. Without a pointer is very difficult है ना चलो
And there are
यहाँ पे थोड़ा useful होगा
different forms in the according to the
loudly बोलो कुछ
according to the species there can be different stages as you can see, and in the falciparum there can be seen multiple ring inside the RBC. In the vivax there are single ring forms can be seen. Also there are gametocytes, seeing different types of gametocytes for different species. In rapid diagnostic test, it is based on two antigen, one antigen and one parasite enzyme, PF-HR-P2 and lactate dehydrogenase. This is a depiction of how to do the rapid diagnostic test. At in the EDTA vial, we have to take the blood and we have to add in the sample well using the blood drawer. In the well we have to put 5 microliter of blood, then we have to add 2 drops of buffer well and wait for 15 to 20 minutes to development of the markings for the test, and there will be 3 lines, one for the control, one for Plasmodium falciparum, one for the vivax. This is taken from 2013 national guidelines by NVVDCP. This is showing that if microscopy available in 24 hours, they are according to that, if diagnosis is made, according to that treatment to be started. And if there is only monovalent RDT is available and there is increased prevalence of Plasmodium falciparum, we have to do the monovalent RDT test. According to that, if the test is positive, we have to start the treatment according to where the patient is from, and if the test is negative, we have to start the chloroquine, and after the test we have to during the testing RDT we have to also prepare the slide and send it for microscopy. After the test results has come, if the patient is Plasmodium vivax, then we will continue the treatment. If there is positive for Plasmodium falciparum, we will change the treatment to Plasmodium according to Plasmodium falciparum. And this is showing the RDT if there is bivalent RDT is present.
What are the different types of RDT you use?
Monovalent and it's a bivalent.
Different types of base test होते हैं ना?
Artesunate and
इसको प्रेजेंटिंग क्यों करवा रहे हो? हाँ बताओ.
So ACT artisanate and it's ACTL and ACTL their artemether and it's a lumefantrine. Artisanate it's a combination based therapy. Artemisinin combination based
हाँ वो
therapy.
आगे बताओगे ना भैया, ठीक है, ये ज़्यादा मत बताओ, आगे बताओ.
इसको प्रेजेंटेशन दिखा के कोई लॉट ऑफ थिंग जो बात कर लेंगे बाद में.
Things to consider in a high clinical suspicion. If the microscopy is negative, we have to repeat the test 12 to 24 hours for 3 sets. And if the RDT microscopy, for RDT, if the test is negative, microscopy should be followed. If they are not present, then RDT can also be done after 24 hours. In cases of HRP2 based RDT test, there can be persistence from the previous infections, so it may cloud our diagnosis for the same. Additional laboratory findings, we can see normochromic normocytic anemia, normal or mildly depressed leukocyte count, thrombocytopenia, elevated ESR, mild abnormality in renal and liver functions. Now we will discuss about the treatment of malaria. Treatment I will discuss first about the treatment of Vivax malaria. In chloroquine, chloroquine and pymaquine, using chloroquine and pymaquine to treat the Vivax malaria, and chloroquine is given at 25 mg per kg body weight divided over 3 days. On day 1 10 mg per kg and day 2 10 mg per kg, day 3 5 mg per kg, and pymaquine is given at 0.25 mg per kg daily for 14 days. In case of treatment of falciparum malaria, in northeastern states, ACT-AL co-formulated tablet, artemether 20 mg and lumefantrine 120 mg with pymaquine 0.75 mg per kg on day 2 to be given. This is again taken from the 2013 national guidelines, weight and age based treatment guidelines. For example, 5 to 14 kg weighted patients, total dose should be given to be 20 to 20 mg of artemether and 120 mg of lumefantrine, one tablet twice for 3 days. Treatment of falciparum malaria in other states, artesunate for 4 mg per kg for 3 days, and sulfadoxime 25 mg per kg plus pyrimethamine 1.25 mg per kg on a first day, and pymaquine 0.75 mg per kg on day 2. There is also a treatment chart from 2013 guidelines. Why artemisinin based therapy is chosen? It include one artemisinin based plus one long acting additional drug. Artemisinin rapidly clears the parasite load and improves the symptoms. Long acting drug will clear the remaining parasite, and use of the combination prevents resistance. For special conditions, we have to see for G6PD deficiency. In G6PD deficiency, if there is semi-quantitative G6PD tests are available, then we can see if the G6PD levels are more than 70%, we can give tefenoquine or pymaquine, and if the G6PD is 30 to 70%, then we have to give lower doses of pymaquine, it's 0.5 mg per kg for 14 days, or if there is less than 30% or there is qualitative G6PD present and the test is less not present, negative, then we have to consider giving 0.75 mg per kg weekly for 8 weeks under strict guidelines.
Sir, even if it's G6PD deficiency, they are giving pymaquine, but normal dose is 0.75 mg per kg, but then they need 1 mg per kg, which is 5
For
mg.
that is for
No. Even 0.2 mg per kg.
बहुत सारी स्टडीज ऐसी हैं जहाँ पर हमने हायर यूज पे देखा है कि इट ऑल डिपेंड ऑन ड्यूरेशन एंड थेरेपी रेदर देन द डोसेज। ड्यूरेशन अगर आप कम करते हैं तो शायद G6PD डिफिशिएंसी में आप बट द एसेंशियल इज देयर। लॉट ऑफ पीपल से दैट इट इज नॉट एक्चुअली हेल्पफुल। आप बताओ क्या करना है?
सर तो नीचे लिखा है Primaquine given as either 0.5 for 40 days may be used in Indian subcontinent and the Americas will be also. Probably this is not from NBU itself.
No, this is from taken from WHO guidelines, new 2024 WHO guidelines.
एक चीज और सुन लो। There is a review article published in NEJM, या तो इस महीने में पब्लिश हुआ है, इससे पहले महीने में 2025 का रिव्यू आर्टिकल है NEJM में, आप जाके पढ़िए। ये इम्पोर्टेंट है, मलेरिया पे एक आया है, NEJM में आया है,
सीवियर मलेरिया पे
Continuing with for severe malaria, we can see the signs and the manifestations. There are 11 signs. Impaired consciousness, Glasgow score less than 11, prostration, generalized weakness, unable to sit, stand or walk, multiple convulsion more than 2 episodes within 24 hours. If acidosis is present and more than 8 milligrammes per liter base deficit or 15 millimole per liter bicarbonate lesser than that bicarbonate levels, or lactate more than 5 millimole per liter. Pulmonary edema if oxygen saturation less than 92%, respiratory rate less than 30, and in auscultation crepitation is present. And hypoglycemia if there is less than 40 mg per dl plasma glucose level, and hypotension or shock if compensated shock is present, capillary refill time more than 3 seconds, and for systolic blood pressure in for adults less than 80, and for children less than 70. Bleeding manifestations is present or signs of DIC, and severe anemia, and hemoglobin levels less than 5, and renal impairment serum creatine levels 3 mg per dl, and hyperparasitemia more than 10%, and jaundice 3 if plasma serum bilirubin level more than 3 mg per dl. For treatment of severe malaria, we can use artesunate based regimen, and 2.4 mg per kg given as an intravenous injection on 0, 12, 24 hour. After that daily, and once the patient able to tolerate orally, we have to shift to the full course of ACT based therapy, and complete the course. And for quinine based regimen, we have to use 20 mg per kg quinine dihydrochloride in 5% dextrose over 4 hours, followed by 10 mg per kg every 8 hours for 48 hours. After that, patient, if the patient when the patient able to take orally, we have to shift to quinine sulfate 600 mg TDS for 5 to 7 days, and for second drug doxycycline or doxycycline 200 mg or clindamycin 450 mg TDS for 7 days. In case of malaria in pregnancy, there may be many complications related to malaria in pregnancy. There can be maternal mortality, pregnancy loss, miscarriage, stillbirth, and premature labor, and low birth weight can also happen. For treatment in cases of malaria in pregnancy, for severe and complicated malaria, it is to be done as normal. Other cases, in uncomplicated falciparum malaria, oral quinine 600 mg 8 hourly and clindamycin 450 mg 8 hourly for 7 days to be used. And preventing relapse during pregnancy, we have to give chloroquine 300 mg weekly oral until delivery. For preventing relapse after pregnancy, treatment should be postponed until 3 months after delivery, and G6PD testing should be done. After that, oral primaquine based on the species involved, 15 mg for oval and 30 mg for vivax, single dose for 14 days. Other special conditions include pediatric age group less than 5 years, ACT waist based, and for PL-HIV cases, if on cotrimoxazole, avoid ACT SP, and if on efavirenz and ziravirin, avoid ACT amodiaquine. For chemoprophylaxis for shorter duration of travel, we can use doxycycline 100 mg once daily for adult, or 1.5 mg per kg once daily for children, started 2 days before the travel and continued for 4 weeks after. For mefloquine is used for a longer duration of travel. It is used 250 mg weekly for adult and started 2 weeks before and during and 4 weeks after the exposure. For immunization, there are development phases of vaccines. The RTS-S/A/S01 and R21/Matrix M vaccines, and these are in the trial phase 3, and for monoclonal antibodies, it is the early trial phases. They are present L9LS and CI43LS. There are ongoing challenges regarding malaria. The first, the burden of the malaria, and the development of resistance in mosquitoes for insecticides, and improving the malaria diagnosis. Drug resistance, there are few cases in the Southeast Asia region, and in the northeast regions of our country, there are development of drug resistance is there, and reducing malaria transmission is also a challenge. In my presentation, the take-home messages are: malaria still a major health problem in India. We have to take necessary steps for eliminating the malaria. Proper history taking and clinical examination is utmost important. Prompt diagnosis and early initiation of treatment is important to reduce the morbidity and mortality related to malaria, and looking for danger signs of severe malaria will reduce the mortality related to it, and we have to test, we have to send testing for G6PD enzyme, and repeat testing in high suspicious cases. Thank you.
This was your first presentation?
No,
Second presentation. So you must have some prior micro teaching during the name. I'm just going through your presentation. So you started very good. You started with the case scenario. You tried to engage the people and try to get their attention. But later on, you actually missed the bus section. So your slides were very good actually. Very clean slides were there, and there is hardly any overcrowding in slides. So your slides are very clean, very good. The problem with that, even there was some busy slide where you discussed the complication of malaria, because this was a busy slide and you wanted to incorporate everything in a particular slide. You highlighted the important things, that if these things are there, you should, it's a red mark. There is hardly any interaction during your presentation. After your first slide, there is hardly any interaction with the audience. So many of them were actually sleeping. They were sleeping. They were discussing whatever they want to discuss. They were discussing actually. So there is hardly any interaction. You were not able to engage the audience. Modulation of voice, which was missing here. You sometimes this is the problem with me also. Modulation, sometimes you raise your voice. If you want to emphasize something, you just raise your voice, or you can decrease the intensity of frequency. So there is hardly any change in the intensity, whatever amplitude of the voice or frequency of the voice. It was in the same pace. Your topic was not well researched. So maybe, as I told you, that there is a review article published recently in NEJM. So it was not, none of your slides were given a reference was taken from this place. So you should have a more researched approach. And you are not well prepared for this presentation, I must say that. When the question they were asking, I asked you a question that what are the different mechanism, what are the different things that that is used in RDT. So sometimes you fumbled actually, you are not able to explain the things as it should be. So these are some of the micro teaching, and probably with this input you will, I'm sure that you will do very good in your future presentation.
So, thank you, sir. So, Shantimoy, and this is for all other residents also who are presenting. So, please, I just want to sort of highlight that your presentation is very important for your overall assessment, okay? When you come and present here, you are being seen by all faculty. We are making our notes and we are assessing your overall development as a resident in the department. And we see a lot of the times that when the residents go from first semester to sixth semester, they often increase drastically in their presentations, quality of presentations and the research that they do behind. So please take this presentations very seriously. You are being marked and you are being watched. And all of these presentations should be, you should research well, you make a good presentation. We are not asking you to make animations and all that. We are not asking you to spend time making the slides. Slides is a, simple slides is a professional slide. We want professional, we are not art students doing a bachelor in fine arts. We are MBBS students or MD students doing MBA. So these are professional slides which we expect, so slide quality was really good here actually. So simple slide is what we expect. But when we are doing a professional presentation, we expect you to read well. Okay, so you must be able to read well and you should have the knowledge behind, and practical knowledge is also what we expect you to do. So in RED, how it is, this knowledge is going to be useful. Do we have the RDT test that you are suggesting? Do we have the thin and thin spill? So, in this scenario, whatever is aspect to RMS, so you should contextualize it to your MMSC also, whatever is relevant. So please take all these presentations seriously, and I will do a presentation on how you should do a presentation also, hopefully in the next session, next class. If we have time today, I can do it today also, but I don't know how much time we have. So I would like to do a presentation on how to make an effective presentation. I have some. So what is the next presentation? So all the best. Good work, Shantimoy. But definitely room for a lot of improvement. Okay, we are hoping that because your second presentation only, but there is definitely room for improvements. Okay.
कोशिश करो कि स्लाइड से ना पढ़े। बहुत बार क्या है कि हम भी बिना स्लाइड देखे नहीं कर सकते।
हल्का सा देख लो।
थोड़ा सा देख लिया।
A lot of these comments are also for other presenters, है ना? So we did not make specific comments to everybody, but generally I am just making comments. Okay, so we will have some teaching on that also.
Okay. So I will continue the discussion of today's topic, tropical diseases. Actually, May is coming up, so this is the part of the year where we'll get all of the tropical diseases.
You said the lull before the storm. So the storm is coming.
Yeah.
We know it is going to come July onward.
July onward, there is this huge surge of febrile
All
illness.
tropical illness.
It's tropical illness basically. Dengue, malaria,
Everything will come. Chikungunya, everything will come.
That is why we always need around May, June, that you should know how to manage this patient.
And we had a session on heat stroke also, because heat storm is available. So all the academics has been designed so that it is applicable. अब यही lecture अगर November, December में लेंगे तो
Yeah, no point, yeah.
role नहीं है. So
Actually, we are discussing at the right
that
point.
the knowledge remains fresh, and that you all read right now, and go home and read about all these topics.
Okay.
ऐसा
So.
नहीं है कि अभी मई में कर लिया तो जुलाई तक भूल जाएंगे इसको।
हाँ।
ठीक
ठीक है, carry
Okay.
it, yes.
So, since we are somewhat short of time, I will try to cover as fast as possible. I will be discussing briefly about leptospirosis and scrub typhus. So, first about leptospirosis. Leptospirosis is a zoonotic disease caused by the pathogenic spirochetes of the genus Leptospira. Other spirochetes are like syphilis and Borrelia, etc. So, the thing about leptospirosis, the global burden of leptospirosis is actually pretty high. but it is heavily under-recognized and under-reported entity. It's even listed in the 17 most under-reported diseases by the WHO. Coming to the microbiology, it's a spiral-shaped organism, highly motile, and it's not usually seen by a regular microscopy techniques, by a gram stain or all those things. And we need special equipment like a dark field microscopy or immunofluorescence or silver staining. Okay. So your dark field microscopes looks like. Okay. Epidemiology, since this is a tropical disease, the tropical belt of the world is actually burdened by this disease, and India mostly, especially the South India, falls in this tropical belt, and there are at least 1 million cases every year. So you can see the red, it's mainly concentrated in the tropics. In India, again, South India, most cases are seen in South India. Around 25% prevalence is there in South India, and North India sees pretty much less number of cases. And the cases are seen around monsoon because the cases are transmitted through the contaminated water bodies. So around monsoon. Exposure to rain and occupational hazards also pose a risk, like farmers and military exposure, agriculture workers, sewage workers, and all those things. As a medical student in Kerala, during a 2018 monsoons, we were also part of the Leptospira campaign. We had to go around all the camps spreading doxycycline, giving doxycycline and spreading spreading information and giving away doxycycline. Yeah, so we are part of that. Most cases are seen in Andhra, Kerala, Tamil Nadu and Orissa.
Selection of sentence and words है बहुत important होता है. जैसे एक नेताजी बोल रहे थे कि प्रधानमंत्री की अगुवाई में जो पहलगाम में जो अटैक हुआ है उसकी हम निंदा करते हैं. Words are very
So, okay, come on. So, some things about the reservoir and the host. Mammals are the primary host and reservoirs. Almost all mammals can accommodate this organism. Even though rodents are the most important ones, every mammals like swine and cats, dogs, buffaloes and horses, everything can host. These organisms actually reside in the renal tubules of the organism, and the organism the animals mostly have an asymptomatic infection or may have clinical infection or maybe adverse pregnancy outcomes also. And the asymptomatic animals carry around these organisms in the renal tubules and intermittently shed through the urine throughout the life. And when it comes to the environment, these organisms can stay in the environment, contaminated soil or in the water bodies up to months. And humans become the accidental host when they come across this contaminated soil or water, and the portals of entry include abraded skin or direct mucosal exposure or even ingestion. The population risk, as we mentioned earlier, farmers and sewage workers and even recreational and endemic travel, obviously. Coming to the most important part, knowing the clinical features is important for us to start suspecting the cases. Most infections are usually asymptomatic and mild and self-limiting. In patients who have a clinical disease, 95% of the cases can actually fall into two different scenarios. 90 to 95% of the cases fall into a thing called anicteric leptospirosis, which is usually benign and self-limiting. And only 5 to 10% of the clinical cases fall into the icteric leptospirosis, which is the most sinister one. And most probably we will be dealing with these cases in our area. Coming to the anicteric leptospirosis. The disease per se is caused by the bacteremia in the blood. The symptoms usually begin around 10 to 15 days after exposure, and the symptoms usually fever and other symptoms. Sometimes the disease may show a biphasic response. Initially there will be a fever, and after the bacteremia has been cleared by the antibodies, there will be symptomatic improvement. And in a minority of cases, the symptoms come back because of the immunological complications per se. The acute phase lasts for around 2 to 9 days, and the immune phase can last up to a week or so, maximum up to 1 month. The clinical features of acute phase. It usually starts as an acute febrile illness with rigors, intense headache, myalgia. And myalgia, it is more specific towards the calf region and lower back ache. And these symptoms are seen in at least 100%, 70 to 100% of the patients. Other symptoms include nausea, vomiting, and GI symptoms in 50% of the patients, and upper respiratory symptoms in a quarter of the patients. In physical examination, one remarkable thing about leptospirosis is in most of the patients, we can find a conjunctival suffusion. And there will be hepatosplenomegaly, and a rash, maculopapular rash will be seen in up to 40% of the cases. In labs, in CBC, what we usually see is neutrophilia. Anemia and thrombocytopenia are not so common. There will be mild elevation in ESR and CRP, mild transaminitis. And one thing particular is creatine kinase will also be high because of mild rhabdomyolysis. AK is rare in this anictoric phase of anictoric leptospirosis. Then comes the immune phase. Immune phase is when the bacteria has been cleared and the antibodies are formed, and it is usually followed by a brief asymptomatic period. The symptoms again come back, the fever and body aches and myalgia all come back, and two hallmark features in this immune phase is actually meningitis and uveitis. The meningitis is usually aseptic. If you do a CSF, the culture will be negative, but there will be mild neutrophilia and mild elevation, modest elevation in proteins, and the glucose will mostly be normal. It has a good prognosis. It usually resolves without a specific intervention and resolves within few days. The thing about uveitis is it can be unilateral or bilateral, anterior or posterior, and it also has a good prognosis without any vision loss. But only thing is the long-term sequelae of leptospirosis, the patient can have recurrent uveitis episodes even after infection. Then comes the icteric leptospirosis. So it is seen in
What is the most common ocular manifestation?
most common ocular manifestation is conjunctival suffusion, conjunctival congestion. It is actually seen in most of the patients. But in the immune phase, patients can have uveitis also. In uveitis, the patient can have more severe symptoms like painful red eye and may have transient visual disturbances, but usually resolves with a good prognosis.
So they will always have an immune phase, or
No, in minority of patients.
minority? No? Conjunctival suffusion is one of the most common, very common, one of the most common presentations in these patients. So
Yeah, majority of the patients we will usually see.
80 to 90% cases we can see. We are talking about uveitis. Uveitis is uncommon.
Yeah. So next we are discussing about the most
Circumcorneal redness is there also.
Circumcorneal condition is more common in uveitis. You may see flares,
Pain.
pain is more
Pain
common.
is very, in uveitis there will be severe pain.
conjunctivitis is very
Pain also.
So again, a minority of patients, around 5 to 10% of the patient falls into this icteric leptospirosis, which is a more sinister form of the disease. This is called the Wales disease. Basically, the manifestation like the fever and general body aches and headaches will all be similar, but except there will be organ dysfunction in this type of leptospirosis. It's a rapidly progressive multi-system disorder with high mortality. The case fatality around 1.5%.
But it is called icterohemorrhagic.
Yes. Yes, it's also called icterohemorrhagic. Most common manifestations, organ involvement is liver and kidney, and pulmonary involvement being rare but fatal. The clinical symptoms, again, fever and conjunctival suffusion is very common. In hepatic, there will be jaundice, a modest elevation in transaminases. The liver failure is actually rare, and the liver part of the leptospirosis actually resolves on its own with good prognosis. In renal, there will be AKI. It could be oliguric or non-oliguric. In oliguric patients, at least half of the patients might require RRT, and some may even progress to CKD. In pulmonary, manifestations are only actually 5%, but the mortality, if a patient has a pulmonary manifestation, the mortality come up to 50 to 70%. It usually presents as DAH. The patient will start having cough, breathing difficulty, hemoptysis, and external bilateral infiltrates will also be seen, and will be accompanied with DIC. Other manifestations include myocarditis, rhabdomyolysis, DIC, etc. Can go into full-blown mods. The diagnosis, These are briefly the different categories of diagnosis that we can come across. Microscopy with the dark field microscopy, which is done in our AIIMS lab. Bacteriological, we can do culture. Immunological, ELISA, detecting antibodies by ELISA, or the historical standard, which is MAT.
What's MAT?
Microscopic agglutination test. Microscopic agglutination test is actually very cumbersome and is only done in very few reference labs throughout the world. The problem is that they need to maintain live cultures of different strains of Leptospira to do the MAT. So easily it is not done for routine evaluation. Only for research purposes they use MAT. And molecular PCR. In our lab, we have a 8th floor special bacteriology lab in our convergence block, where they do this Leptospira, Leptoscrub, Chlamydia, Legionella, Bartonella, all those things they do there. For leptospirosis, they do microscopy, they do culture, they do PCR, and they do antigen for all the samples that we send.
So without technical thing. So how do we send the sample?
I will come to that.
In R&D, how do we do it?
Yeah. So before that, I will just briefly explain how the different like organisms and antibodies and the timeline in various body compartments. So first, when the patient is getting infected, the first week will be the asymptomatic incubation period, where the bacteremia will be high, but we will not detect it, the patient is not presenting clinically. The second week or the first week of clinical disease is when the body has bacteria, and this is the time when we can do. This is the time when we can detect the organism via PCR or by culture or by microscopy in the blood in the first week. Okay. In the second week, the bacteremia is cleared and the bacteria is shed in the urine, and the antibodies will be found. So in the second week, what we can do is we can detect the organism via PCR or culture in the urine, or we can do antibody testing in the blood. Okay. So PCR is actually rapid and accurate and can be done on blood in the first week, and can be done on the urine in the second week. Overall sensitivity in the blood is low and the specificity is high. But however, a meta-analysis of 11 studies showed that when we do testing on blood and urine together, there will be a pooled sensitivity of 87% and 97%, which makes it important for us to do testing on both blood and urine, which we often miss in our AD. Serology measures specific IgM and IgG antibodies, and it is usually valuable after first week, as I mentioned. Either a single high titer or a 4-fold increase is what is required. This is actually the Leptospira sending form in our ED. What we usually do is we send the Leptospira samples in a culture form in an EDTA vial and a yellow vial. I actually talked with the guy who does run the things in the lab. They said they will still do the investigation if we send through the wrong forms also, but ideally this is what is required. So with the citrate vial, they run PCR and microscopy, and with the serum vial, they do the antibody testing. And this is paired with urine testing also, which increases the overall sensitivity and specificity. We need to fill this form and send in these citrate and serum vials, and the lab will be run between 9 to 5 p.m. And what they said is actually they do the testing only once in a week, but if you are getting a patient with high suspicion, we can just call up the lab and they will run it faster for us.
So all this information has to be filled up, and you have to send 3 samples. One is a 2 ml in plain vial, in a citrate vial, and a urine in plain vial.
Sir, I think ये पहले था अभी हम लोग बस culture form में लिंक टू culture form. One will be for PCR for ELISA and one for IgM antibodies. PCR and IgM.
Actually, 3 days back I went to the lab and they said they accept both the forms, but this is the standard form which other departments all send, and we usually send in a culture form, but this is what is more accepted.
No, तो अभी आप क्या कह रहे हो छोटे? हम क्या फॉर्म भेज रहे हैं? अभी ये वाला नहीं?
culture वाला 2071 वाला जो culture के लिए भेजता है वही.
तो ये तो कह रहा है कि this is what
They accept both the forms, but this is what they prefer more. That's what they
They
said.
prefer more, but this has a lot of limitations, sir. To fill this form, it takes like 25 minutes. It has like
that
so
is
many things to fill. And
that is
ये
true.
मिलने के लिए पहले एक HO को भेजना पड़ता है. भेज के वो पहले कुछ भी बोलता है तो दोबारा भेजना
एक
पड़ता है.
बार facility से discuss कर लेते हैं.
Now I gave a copy to the lab too, and now they have a soft copy they can take a printout. The issue comes is when we have to send the urine sample, we need this form. So only if we send the urine sample, the sensitivity of PCR actually increases to 87%. Otherwise, the sensitivity is low.
Initially बहुत मुश्किल करता था तो you know Anuj sir, HA Anuj. Sir, you know HA Anuj. जो रात में करता था फिर लैब में चला गया. तो उसने लैब में बात करके उसका पीछे श्रीश सर और मेहुल सर को पढ़ा था ऐसे 1-2 हफ्ते. फिर they started accepting our sample in that just the blue form. Initially they never used to accept.
कैसे भेजते हैं?
वही तो अपने पास डिस्कशन चल रहा है सर. ये 3 सैंपल्स भेज रहे हैं. This is what they are suggesting कि इसको फॉर्मा को करो. But ये यूजफुल नहीं है. वो ये कह रहा है सलीम कि this is a very tedious form to fill up because के दोनों तरफ भरना है. ये अवेलेबल नहीं है. 2 पेज है दोनों साइड में.
दोनों साइड.
इससे बहुत चीज है जो हम हिस्ट्री में भी नहीं पूछते.
Actually, they are doing a research also. They need some further
रिसर्च कर रहे हैं.
So इसलिए अनुज भैया अनुज भैया he is now posted in lab actually. उसको इमरजेंसी से हटा दिया क्योंकि 2 जगह काम कर रहा था. इमरजेंसी में लैब में. तो कॉन्ट्रैक्ट में हो गया कि एक ही जगह काम कर सकते हैं. तो वो लैब में चला गया. तो जब लैब में चला गया इस रिसर्च सब लोग
जब अनुज चला जाएगा तो सिस्टम फेल कर जाएगा.
वो है इसलिए मैं बता रहा हूँ कि
सिस्टम शुड नॉट बी लाइक दैट ना. ठीक है चलो उसको भी लैब सर ये हमें देखना पड़ेगा माइक्रोबायोलॉजी. How do we streamline the collection
ये
and
इतना ज़्यादा information कहाँ से?
नहीं ये एक और पेज है इसके पीछे. 3 पेज. 1 to 3rd page.
Actually, 2 sides only. This photo. I have it.
नहीं 3 पेज है सर. 3 पेज.
और
ये तो सिर्फ पहला दिखा है.
9 to 5 ही भेज पाएगा. हाँ that's right. But that's why blue color form वाले we can send 24 hours. Just say not it yes.
24 hours नहीं, still 5 o'clock only. Till 5 o'clock. Only 9 to 5.
Then what we can do during the peak season ना सर हम उनसे रिक्वेस्ट कर लेंगे कि इसको आप एटलीस्ट 3 times a week रन करें. And PCR
Special bacteriology lab है sir.
PCR के लिए ना
PCR and IgM.
The special bacteriology lab is
ये
sir.
डॉक्टर निशांत वर्मा और डॉक्टर तनु साहब कौन है?
They are faculty who are doing.
बात करना. ठीक है next carry on.
Differential I see sepsis with mods from any cause, and again all tropical fevers present kind of similarly with malaria, dengue, chikungunya, enteric fever, scrub typhus, acute viral hepatitis all have a pretty similar syndrome. And non-infectious may we have ANCA related vasculitis, TTP, HUS can all present similarly. The treatment for mild disease it is actually for adults we treat with doxycycline oral 100 mg BD for 7 days. For pediatrics also it is doxycycline 2 mg per kg for 2 divided doses. American Academy of Pediatrics has said that the use of doxycycline for less than 21 days in pediatrics is actually safer and doesn't cause tooth discoloration like other tetracycline, so it's fine. And for pregnancy, since we cannot go for doxycycline, we go with azithromycin or amoxicillin. When it comes to severe disease, the different agents used are penicillin, doxycycline, ceftriaxone and cefotaxime. There are multiple studies comparing the different efficacy of all these agents and all reported similar efficacy, and there is, we cannot say which is superior than the other. Since we have doxycycline and ceftriaxone in our AD, we can use that. Same regimen applies for pediatrics and pregnant women also. Chemoprophylaxis, even though data is lacking, this is what we give for chemoprophylaxis in high risk areas, for high risk workers and during floods, 200 milligram per week for 6 weeks. Okay. Then we discuss about scrub typhus. It is a mild-borne infectious disease caused by a bacteria called Orondia tsutsukemashi. It is also one of the greatest public health concerns, especially in the Asia-Pacific rim. It's an obligate intracellular organism, which means we cannot stain it or we cannot culture it. And once it enters the body, it infects wide range of host tissues like endothelial cells, macrophages, dendritic cells, all sort of cells. The disease is mainly burdened by the Asia-Pacific rim, and around 1 million cases are seen per year. A recent 2025 March-May study has come out, which has been published from India, where they followed up 30,000 cases for 2 years, and every 6 weeks these investigators followed up these 30,000 patients and investigated and inquired whether they developed a fever or not. If they developed the fever, they tested for scrub typhus. And in their study, they found that the incidence of scrub typhus was 328 patients in the 30,000 population, which means like 6 cases per 1,000 people years.
So this is a normal patients, they just...
Yes. In Tamil Nadu, the study happened in Tamil Nadu.
Yeah, but just not with asymptomatic people.
Asymptomatic people, they...
followed up cohort study like Framingham study for 30 years.
For 2 years, 30,000 people.
30,000 people, 2 years.
Yeah. And whenever somebody had a fever, they tested everything, tested for scrub typhus. This has been published in NAJM and it came in March 2025.
March 2025 NAJM publication.
Yeah.
Actually, group and scrub typhus में ना combination therapy रहेगी, same group.
Yes. Interest trial.
Basically, इसमें CMC value सबसे है.
Peters.
Varghese.
वही group है.
Yeah. Okay. This is the Asia Pacific Rim where see most of the cases. Okay. The reservoir and the host is the larval mites called chiggers. The adult mites actually reside on the rodents and mostly seen around the bushes. And when they produce a larvae, the infection passes transovarially, and these larvae go about and actually accidentally bites a human, and so man becomes the accidental host. Once it enters the host, the organism disseminates widely throughout all the host tissues.
एक patient आया था वो देखा था this student उसको bite हुआ मैं share करता हूँ.
So again, I'm quoting the data from the recent study. Most cases were asymptomatic, and about only 22% of the cases required hospital admission, with 9 severe disease with organ dysfunction or adverse pregnancy outcomes. The case fatality was at 1.5%. The disease starts as an acute febrile illness, usually around 10 to 15 days after the bite. And the fever actually stays for extended periods, the median time being 14.4 days. The fever is like any other tropical fever syndrome. It is associated with intense headaches and body aches and myalgias. Coming to the rash actually starts in the abdomen and spread towards the peripheries. Usually what we see is a macular to a macular-papular rash. And at least half of the patients show a macular-papular rash like this. The characteristic eschar what we see is at the site of the chigger bite, there will be initially a non-pruritic papule, which then because of the underlying intense vasculitis, it necroses to form an eschar. And we often don't see this because different studies report different incidence of the eschar. With the recent study which I said, they reported incidence of 18%, with other studies telling up to 87% of incidence. Even if it is present, we might overlook because this actually preferentially bite warm areas, so it might be in our axilla or flexural folds of the groin areas. So we need to search for it. Other symptoms, lymphadenopathy. Like how we said, we find conjunctival suffusion in leptospirosis. What we find here characteristically is lymphadenopathy. Initially starts as localized lymphadenopathy and then it forms a generalized lymphadenopathy. At least one fourth of the patients have GAT symptoms, nausea, vomiting and diarrhea. And 2/3 of the patients have respiratory symptoms ranging from mild cough to full-blown ARDS. And CVS patient may have relative bradycardia. Relative bradycardia is defined as less than 10% rise of heart rate per degree of rise of temperature. To myocarditis. Myocarditis has also been reported scrub typhus. In CNS we have meningitis and seizures and altered mental status. And renal again AKI with at least 13% of the patients requiring dialysis. So labs we have thrombocytopenia with TLC count being either elevated, normal or higher. Other lab findings corresponds to the specific organ dysfunction that we find. The diagnosis. The thing about scrub typhus is that the more delay is there in starting the antibiotics, the adverse outcomes will also be higher. There is a study that found that delay in starting antibiotics is independently associated with worse outcomes. So the treatment is always started presentively. Whenever we suspect scrub typhus, we start the treatment. and testing is only done to support the diagnosis that we have already made. Again, we have serology and molecular. Serology via IFA with we detect antibodies, IgM and IgG antibodies, either a positive IgM or a high titer of IgG. Immunofluorescence assay, or a fold for rise of IgG is what is required, and this is a presumptive diagnosis. For confirmation, we need a PCR. Even though it has low sensitivity, the specificity is high, so we can use it to confirm the diagnosis for ruling in the diagnosis. In our lab also, in our special bacteriology lab, these are the two tests what they do. So for
IgM and PCR.
yes, IFA and PCR. So for all the samples we send, they do these both tests. So usually we need the EDTA sample for them to run the PCR and the serum sample for the serology. Again, this is the form. This is a different form.
And when we are sending, so we'll be sending all three together. So I think
So maybe but less than leptospirosis.
नहीं, I don't think you should fill this form, है ना? मुझे लग रहा है कि ये
Yeah.
over study चल रही है without it.
हमने पढ़ा नहीं ऊपर में लिखा हुआ है
Multi-centered study. See, this they should be filling if they are doing study. We are not part of the study. We will not do this.
Okay.
ठीक है? So I sir, आप announce कर दो. This should not be filled.
नहीं, अभी हम फिल नहीं कर रहे सर, अभी माइक्रोबायोलॉजी फॉर्म में भेज रहे हैं, अभी ये फॉर्म को यूज नहीं कर रहे।
If they are doing study, they should come and fill up the form. We are
Yeah,
not
they said they will accept our microbiology forms also. Only issue is when you have to send the urine sample also, they need this sample.
Why?
That's what they said, but otherwise.
No, urine के लिए भी बनवाओ सर. ये सब क्या स्टडी में या तो फिर सलीक का नाम डालो. सलीक का नाम नहीं स्टडी में सलीक से फॉर्म बनवा.
कहाँ है मेरा नाम?
डालना है.
नाम है।
You know, you are not part of the study, and still you are being asked to fill the form.
नाम नहीं तो नाम नहीं
Correct.
Okay. Again, we initiate treatment without delay. Even when we have suspicion of the disease, we start treatment. Delayed antibiotics has been independently associated with adverse outcomes, including major organ dysfunction. So we treat scrub typhus depending on whether the disease is severe or not. So we need to classify if it is a mild to moderate disease or a severe disease. Severe disease means there is organ dysfunction. That's all. For mild to moderate disease, we treat with monotherapy, either doxycycline or azithromycin. Again, different studies comparing doxycycline versus azithromycin showed no which is superior. No superiority, both are equal. With azithromycin, some studies quoting azithromycin is better tolerated. Durations 7 days. 5 to 7 days. Severe. For severe disease, the historical standard was to give doxycycline 200 mg BD for the first day, followed by 100 mg BD IV for the next 6 days. But however, again, a study which has been come out recently in 2023 September, again by the same principal investigators in Tamil Nadu, where they did a randomized trial on 786 patients, and they studied the primary outcome, which was all-cause mortality, 28-day mortality, and they studied in 3 arms: patients receiving doxycycline, patients receiving azithromycin, and patients receiving both. They compared 3 of them, and they found that absolute 13.3% risk difference in patients who received both. 13.3% absolute mortality benefit. Those are secondary outcomes. Primary outcome was all-cause mortality 28 day and persistence of organ dysfunction at day 7. So they found an absolute 13.3% risk difference. So which makes it.
दोनों ड्रग्स का and which outcome are they studying?
All-cause mortality at 28 days. And persistent organ failure at 7 days.
So then when we see a patient, we should start combination.
Yeah.
मैंने
So for all scrub typhus cases, when we suspect a scrub typhus case with an organ dysfunction, this is how you should go about. Doxycycline 200 mg BD for the first day, followed by 100 mg for the next 6 days, and for azithromycin 500 mg IV BD for the first day, followed by 500 mg OD for the next 6 days.
So this is IV or
IV.
azithromycin IV है?
Yeah.
Or is it doxycycline there?
Severe. Again for lepto and scrub, we don't have any vaccines per se. What we need to do is like personal protection and like health education. Just don't get involved, like get into flooded areas and avoid chigger bites. That's all. Thank you. Second.
Okay, so any questions to Mahadev? I think that was, just enough for the day, and I just wanted to comment a little bit on your slides. So the slides were good. That was not a lot on the slide. Only thing I thought that the background was great, but the fonts or the color of the font was matching the background, so you could have a little bit more contrast. So the visibility on the slide would have improved. Otherwise, I think you read well, and I think it was a good presentation. So.
Grey versus grey.
Good.
And he took a picture